Okay, so assalamu alaikum everyone. My name is Ibrahim. I'm a second year medical student. First off, Ramadan Kareem, taqabbal Allah minna wa minkum salih al-amal. May Allah fill these last 10 days with forgiveness and mercifulness, and inshallah your exam goes well. We'll be covering all of histology today, all of it. For the endocrine portion, I included all of Dr. Yaqeen's slides on the histological portions, and I included questions, and I also went over the lab manuals to make sure nothing was missed from the endocrine portion. For the reproductive portion for Dr. Annie's lectures, I did go over your transcriptions and recordings, and I took out the most important parts. I looked through previous questions, see which parts were emphasized on the most, and I looked through review sessions. So for the reproductive portion, I do recommend going over your slides just in case I missed anything. But if you're on a time crunch, you can use the PAL session and then go lightly go over the slides. But I do recommend going over the slides for the reproductive portion. But for the endocrine portion, you're good to go. Okay, so these are our objectives for today's session. So we have the pituitary, the thyroid, the parathyroid, the adrenal, and the pancreas. So the pituitary gland, just a little anatomy recap, because I know you guys are very well aware with this, but the pituitary gland is a pea-sized compound endocrine gland, and it's located in the sala turcica, which is the Turkish saddle, and it's located in the base of the skull. The pituitary gland is held by the infundibulum from the hypothalamus, and the infundibulum is like a short stalk. So from the hypothalamus, infundibulum, and then pituitary. And the pituitary is cut into two main portions, the anterior pituitary and the posterior. The anterior pituitary is like a glandular organ, while the posterior pituitary is actually an extension of the brain. So it's lightly stained in histological pictures, while the glandular portion is more darkly stained. The posterior portion is an extension of the brain, as we said, and there are cell bodies from the hypothalamus, and it looks lighter because of the myelinated axons. So here's a picture you can see. This is the optic chiasm, hypothalamus, posterior, anterior pituitary. You can see how much more darker it is than the posterior pituitary. It's more light because of the myelinated axons present there. This is the pituitary stalk, the infundibulum that we were just talking about. Here's another picture. You could see the posterior pituitary. It's much more lighter compared to the anterior pituitary, and the posterior pituitary is lighter because of the myelinated axons. Okay, now I'm pretty sure you guys are familiar with this already. The anterior pituitary releases 6 hormones, the 4 tropic hormones and the 2 tropic hormones. The anterior pituitary synthesizes and releases these hormones, but the posterior pituitary actually takes hormones from the hypothalamus, which produces them, and they store the precursors of ADH and oxytocin. You guys probably know what tropic and non-tropic means. Tropic means that they stimulate other endocrine glands while to act on the target organs, while non-tropic hormones act on the target organs themselves. You guys probably already know this. This is just like a recap. Now, the anterior pituitary gland is divided into 5 main types based on what type of hormones they're producing. So we have somatotropes, lactotropes, corticotropes, thyrotropes, and gonadotropes. Somatotropes release growth hormone, lactotropes produce prolactin, corticotropes produce ACTH, actually POMC first, but then ACTH. Thyrotropes release TSH, and then gonadotropes FSH and LH. Now, this is just based on what type of hormones they're producing, right? But we can also classify them based on staining, and this is how we figure out which cells are present in the anterior pituitary gland. So, the cells of the anterior pituitary gland, we stain them, and then we could see either chromophils or chromophobes. Chromophils are basophils and acidophils, which acidophils stain red and basophils stain blue. Chromophobes stain pale, and more the majority of the cells in the anterior pituitary are acidophils, which are 50% of the gland. So this is the same thing that we guys just discussed in the beginning, but with the staining properties. So somatotropes, acidophils, lactotropes, acidophils, corticotropes, basophils, thyrotropes, basophils, gonadotropes, basophils. So how would this come as a question in the exam? So, before we get into that, the lab pictures, these are from the lab manual. You could see that the acidophils are more reddish and more like red stained, and then the basophils are blue, and then the chromophobes, which are lightly stained. And here's also another picture with the labeling. Now on to how could they ask you a question about this? So this is a question from our exam, from our under Reaper final, and this is how Dr. Yaqeen will be asking you questions. So he'll say, a patient with presents with coarse features, and you notice that his face is different from the driving license issued last year. Which cells are affected? So we mentioned that growth hormone is secreted by somatotropes, which are acidophils. And they mentioned coarse features and that his face changed from last year. So they're probably talking about acromegaly, which is a problem in growth hormone. So the answer would be acidophils. So this is how he'll be asking you the questions on this. Now, moving on to the posterior pituitary, we said that it is an extension of the brain, right? And it's more lightly stained compared to the posterior pituitary. By the way, I think I said myelinated axons previously. It's unmyelinated axons. These are an extension of the brain, and they're mostly unmyelinated axons. It's also called the pars nervosa. The precursors of ADH and oxytocin are stored here. As we said previously, they're actually synthesized in the hypothalamus, then stored here. Now we have two main types of cells in the posterior pituitary. We have the pituocytes and the Herring bodies. The pituocytes are glial cells in the posterior pituitary, and their function is not really known. For the Herring bodies, they're like, so imagine with me like a hypothalamic axon, okay, and at its end, it's like dilated. Why is it dilated? Because it's carrying neurosecretory granules of ADH and oxytocin. So it's holding them there when they want to be released. So it's storing them. And this is this posterior pituitary, by the way, and this is it like closer up. And you can see that the Herring bodies are these dots. No, the Herring bodies are these dilated axon terminal endings. As we said, they're filled with neurosecretory granules, ADH, and oxytocin. The dots are the pituocytes. These dots. And it kind of looks like a hazy painting, and the inflamed ones or the dilated ones are the Herring bodies. Here's another picture. Pituocytes are like the dots. The Herring bodies are like the dilated axon terminals. Here's another picture. The black. So Herring bodies, Herring bodies, Herring bodies. These are the pituocytes, the dots, and the capillaries. And here's another picture also. Now, this is how Dr. Yaqeen will be asking you questions in the exam on the histological portion. So if a 70-year-old female presented with fatigue, dizziness, and confusion, her serum sodium was low, her serum osmolality was also low, and her urine osmolality was normal. Her urine sodium was increased. Which of the following would most likely be hypersecreting? I'm going to give you guys like a second to think. Okay, so the answer is B. Why is it B? Because we said what is produced from the posterior pituitary? ADH and oxytocin. And the problem here is with ADH. That's being hypersecreted. A is anterior pituitary, C is adrenal cortex, and D is thyroid, which we'll be discussing in just a second. So now moving on to the thyroid hormone. Again, a little anatomy recap. The thyroid hormone is composed of two lobes connected together by the isthmus, and it's surrounded by this capsule, this irregular collagenous connective tissue capsule, which like divides the thyroid gland. It divides it into lobes, and these lobules each have follicles. All right. So you could see here, these are the follicles, and they are present in each lobule. And the lobules are separated together by the septa, the capsular septa. And this septa also serves as like a pathway for blood vessels and lymphatic vessels and nerves, so that when the hormones are ready by the thyroid gland, it would release these thyroid hormones into the blood vessels. And these follicular cells have simple cuboidal epithelium, as you can see here. But when they're actively making the hormone, they are columnar and not cuboidal. And I think this is a very like commonly tested on aspect. So make sure you understand that. Now, the inside the follicles, you have this viscous fluid. It's also called colloid, and this is where the thyroglobulin is present. It's synthesized in these follicular cells, which are the simple columnar cuboidal epithelium, and are produced and are like released into the viscous fluid. And as we said, it's lined by cuboidal epithelium and columnar when active. And this epithelium is also called follicular epithelium because that makes sense. It's in the follicle, it lines the follicle, so cuboidal epithelium, or columnar when active. They produce thyroid globulin, as we mentioned, and they release it into the colloid. This colloid stores the thyroid hormone, and the follicular cells are also surrounded by other types of cells here. And these cells are called, you could see them here, these cells. Yeah, you can see them here. These are the capillaries. These cells. They're called C cells or parafollicular cells, and they release calcitonin. Calcitonin is a hormone that's involved in the bone resorption. I don't think you need to know much about this hormone, or I just think you need to know that okay, a bit like surrounding the thyroid follicle, the follicular follicle is parafollicular cells, and these parafollicular cells secrete calcitonin. Now, histologically, this is how you would see it. These are the cuboidal cells or the follicular cells in the follicle. This is the colloid that stores the thyroid globulin, and you can see that these little vesicles here. These vesicles are involved in the transport and the release of the hormone after it's been produced by these this epithelium and released into the colloid. And here's another picture. You could see the follicle and the parafollicular cells here. This is the parathyroid gland because it's like behind of the thyroid. And yeah. Now moving on to the parathyroid gland. The parathyroid gland wasn't mentioned in Dr. Yaqeen's lecture, but it was mentioned in the lab manual, so I decided to include it. As we said, it's embedded in the capsule with the thyroid gland and has two main types of cells, chief cells and oxyphil cells. Oxyphil cells are like acidophilic, while the chief cells are basophilic. So the chief cells are like bluish, and then the oxyphil cells are more of a red color. The oxyphil cells are supportive cells, so they support the organ, while the chief cells produce the parathyroid hormone. I don't think you need to know much about the parathyroid hormone, but I think it'll all be mentioned again in MSK. Actually, it will be mentioned all again in MSK, and I don't think they'll ask you much about it. But just so you know, it increases renal calcium resorption and it promotes bone resorption. Now, moving on to the adrenal gland. The adrenal gland, again, a little anatomy recap, has two portions, the cortex and the medulla. The cortex has three distinct zones, the zona glomerulosa, the zona fasciculata, and the zona reticularis. And how I remember it is that JFR. Remember in renal, when you took JFR, just it's a little mnemonic for you to remember this. And the zona glomerulosa is described by Dr. Yaqeen as a curved cluster of small cells that look like the glomerulus. And they actually do look like the glomerulus. Look at them here. They're curved and they look like the glomerulus. And this part produces what? Produces mineral corticoids like aldosterone. And the zona fasciculata produces glucocorticoids, and then the zona reticularis produces androgens. So how I remember these two is salt, sweet, sex. So salt, sweet, sex, and JFR is the way you can remember which parts come first and what they produce. And then we have the zona fasciculata, which are large foamy cells producing parallel columns. You could see the parallel columns here. By the way, this part is how Dr. Yaqeen described it. This is how the lab manual described it. So it's like a more proper way, or I guess more histological way. And then you have the reticularis, which are compact cells and have a few lipid inclusions, as you can see here. Now, the zona glomerulosa and the zona fasciculata are present during birth, and the zona reticularis develops later in the first year of life. So keep that in mind. We mentioned that this looks like the glomerulus. This is arranged radially in double layers to form anastomotic plates or cords, and the reticularis are arranged in like cords in a net-like appearance, and you could see that here. And I'm not very good at histology, but this is the easiest part that I think I think it's the easiest part. It's very distinct. You can tell between the different layers. So again, looks like the glomerulus, looks like columns, and looks like cords that are like clumped together. Now, moving on to the medulla. So the medulla contains medullary cells, and it synthesizes and stores catecholamines. And it has the medullary cells look like this. They look like anastomosing cords, as you can see. And they're surrounded by venous sinusoids because when the hormones are produced, the catecholamines, they release them into the venous sinusoids. And these venous sinusoids have fenestrated an endothelial layer. So it makes it so much easier for the hormones to be taken up in these venous sinusoids. Now, these are more pictures, as you can see. This is the medulla, this is the cortex. The medulla is way darker stained. It has a more basophilic look then the cortex. And this picture also confused me. So the way I think they cut this picture, I don't know if you guys can see me. They cut this picture like this. So like this is the adrenal cortex. They cut it like this. So the medulla was like towards each other here. And then this is the cortex. So it makes sense, yes. And then we have the capsule, the zona glomerulosa, the zona fasciculata, and looks like the glomerulus, and this looks like parallel columns. And then we have another picture here of the zona glomerulosa, fasciculata, and reticularis. You can't see the reticularis here, like the picture's been cut off. Now, how would they ask you this in the exam? So here's another question for you guys. A 50-year-old patient presented with weight gain, muscle weakness, mood swings, and hypertension. His serum cortisol levels were elevated, and his 24-hour urinary free cortisol was at 220, which is very high. The ACT levels were low, and the dexamethasone suppression test failed to suppress cortisol. Which of the following is abnormal? Yalla, I'll give you guys like a minute. Although I feel like this question is very, very obvious. Okay, so the answer is C, the adrenal cortex. Because they mentioned that his serum cortisol was elevated and that the ACTH levels were low. So that because A is the anterior pituitary, B is the posterior pituitary, D is the thyroid gland. So that has like no relation to it. And I think that's it for the adrenal gland. Now, moving on to the pancreas. The pancreas is an endocrine and an exocrine organ, so it has both portions. The endocrine part of the pancreas is called the islets of Langerhans. The exocrine portion is the exocrine acini in the pancreas. So the islets of Langerhans are surrounded by this. The islets of Langerhans are surrounded by the exocrine acini. They're surrounded by the exocrine pancreas. And there are 5 main types of cells in the endocrine pancreas. We have the beta cells, the alpha cells, the delta cells, and the F cells. The beta cells are basophilic cells and they produce insulin. And the alpha cells are, just a second. Okay, as I was saying, sorry for that. We have 5 types of cells in the islets of Langerhans. We have the beta cells, the alpha cells, the delta cells, and the F cells. The beta cells are basophilic, as you can see here. They're darker, and they produce insulin. The alpha cells are acidophilic. They're more reddish, and they produce glucagon. And then we have the delta cells, which are not in this picture. They're, I think, here. No, I think in the next slide. But they produce somatostatin, and F cells or P cells, or previously known as gamma cells, produce the pancreatic polypeptide protein. And as you know from the name, PPP, pancreatic polypeptide. So that's an easy way to remember it. As you can see here, again, as we mentioned, the islets of Langerhans are surrounded by the exocrine acini. And then the beta cells are there, and then the alpha cells are there also. Okay, so the alpha cells are more present in the periphery, while the beta cells are present more centrally. And here's another picture of the islets of Langerhans being surrounded by the exocrine pancreas. And this is like a zoomed in picture of the islets of Langerhans. And it's not labeled, I think, but on the periphery is the alpha cells. And in the middle, these darkly stained cells are the beta cells because they're more basophilic. The delta cells, no picture shows it very well, but this type of staining will show it very well. It's called the Azen-Mallory staining. It's a special type of staining that allows us to see the endocrine pancreas more clearly. So you could see that the alpha cells are like they appear more red, the beta cells appear more brownish, and the delta cells appear blue. So yeah. Now, we're done with the endocrine portion. I really hope that made sense and everything was clear. Please let me know if you have any questions for that part. Now, moving on to male reproduction. So, a little anatomy recap. The testis is a primary sex organ. It's oval-shaped structure and it's located in the scrotum. And it's covered by multiple layers, which we'll see in just a second. And it's responsible for 2 main functions, gamete production and transport, and the production of the male hormone testosterone. So, how Dr. Annie described this is that the testis is divided into two structures, the wall and the lumen. There's no lumen, so she meant the seminiferous tubules. The wall has 4 layers: the scrotum, the tunica vaginalis, the tunica albuginea, and the tunica vasculosa. Scrotum is the skin. The tunica albuginea The tunica vaginalis is serosa. And serosa, you've seen it before in the lungs. You know how like you have the covering, the viscera and the parietal? It's the same thing here. And the tunica albuginea or the albuginea is a white structure because collagen is white. It's a strong, dense connective tissue. And the tunica vasculosa is weak or loose connective tissue, and it's a stroma for the seminiferous tubules. And the seminiferous tubules contain four types of cells. Sertoli cells, which are the germinal epithelium, the sperms in different stages of development, the fibroblast, and the myeloid cells. These two cells are more likely related to the function of the testes, while these two are more of like supporting cells. Now, the tunica vaginalis, as we said, it's like serosa, like how they mentioned before in CBP in the lungs, how it's covered by a visceral layer and then a parietal layer. Similar here again, you have a visceral layer that covers this part of the testes, and you have a parietal layer, and in between them you have serous fluid. This serous fluid is produced by mesothelial cells in this cavity, and they're supported by connective tissue. And the tunica albuginea is also known for its like thickened portion. There's a thickened portion of the tunica vaginalis, and it's called, wait, I think I just confused you guys, and I confused myself too. Again, a tunica vaginalis has two layers, the visceral layer and the parietal layer. And it has a cavity in between them, which is filled with serous fluid. And this serous fluid is produced by the mesothelial cells that line this cavity. Okay, and it's supported by fibrous connective tissue. Now, the tunica albuginea is the one that we mentioned before, and that's after the tunica vaginalis. This tunica albuginea is the next layer, which is this part, and it also has a thickened portion called the mediastinum, and it's this circled one here. The mediastinum is located on the posterior portion of the testes, and it acts as like a bridge, like a conduit for the entry and exit point for blood vessels, lymphatics, nerves, and ducts traveling with sperms. So the fibrous septa extends from the mediastinum that we mentioned here, so this part here, and it like divides the testes into lobules. And there is approximately 250 testes in one lobule. 250 lobules in one testes. And there's two components of each lobule, the seminiferous tubules and the interstitial cells of Leydig. The seminiferous tubules are the ones that we said they're lined by Sertoli cells, and there's the sperm factory and for sperm transport. And then the Leydig cells are the interstitial cells that surround these seminiferous tubules, and they produce testosterone. Now, these are the cells of the testes, the Sertoli cells that line the seminiferous tubules. They're simple columnar epithelium, and they have tight junctions, so they form the blood-testis barrier. They also have the fibroblasts and the myeloid cells, which are the cells of the lamina propria. You guys already know this. We have the epithelium, the basement membrane, then the lamina propria. So this is the epithelium, the basement membrane, and then the lamina propria has these two cells. The myeloid cells are contractile cells that move the sperm out because they can't move yet. They're still very young. And then surrounding the seminiferous tubules are the Leydig cells, which are the ones that produce testosterone. Now, this is just like a recap, everything for you in one slide, the structure, the function, and their location. So seminiferous tubules, germinal epithelium, Sertoli cells. Function is the sperm production and testosterone production. Testosterone production by the Leydig cells that surround them. And there are three kinds of cells, the baby sperms, the ones here, and they undergo crazy proliferation, mitosis, and meiosis. The Sertoli cells here, which support the baby sperm, and they're held together by tight junctions, making the testes a immunoprivileged site environment. The lamina propria, connective tissue, and it has the myeloid cells, so the fibroblasts and the myeloid cells, and then the Leydig cells in between, which produce the testosterone. Germinal epithelium, sperm, Sertoli cells, which are simple columnar epithelium, and then the Leydig cells. Now, this is the journey of the sperm. I forgot to mention that. It starts off in the seminiferous tubules and then goes to the epididymis. Now that we're in the epididymis, the epithelium is pseudostratified columnar epithelium with sterocelia. Sterocelia is an actin-based protein. And the epididymis, at its head, I'm assuming you guys know like the head, the body, the tail of the epididymis. The head has thin, smooth muscle, and the tail has thick, 3 layers of smooth muscle. It first has a longitudinal inner layer, a middle circular layer, and an outer longitudinal. It starts to look like the vas deferens because the next stop for the sperm is the vas deferens. So the function is sperm storage, maturation, and where the sperm becomes motile because it gets flagellum. The flagellum moves due to the microtubules. So you could see the pseudostratified columnar epithelium with the stereocilia and spermatozoa in the middle, and then the smooth muscle. The tail has this much like of smooth muscle because it wants to push the sperm out, right? Now it moves into the vas deferens. The vas deferens has pseudostratified columnar epithelium with stereocilia, just like the epididymis, and it has three layers of smooth muscle, just like the epididymis, an inner longitudinal, middle circular, and outer longitudinal. And they help with the delivery of sperm very fast because it has all these three layers of muscle. You could see the epithelium is simple columnar with stereocilia. You can't really see it much because it's not that zoomed in, but that's the epithelium, and their function is to move the sperm from the epididymis to the ejaculatory duct so it could go to their urethra. Now, the next stop is the seminal vesicles. In the seminal vesicles, what is their function? They produce seminal fluid. They produce 70% of the seminal fluid to keep the sperm in homeostasis. It kind of looks like a honeycomb, and it has pseudostratified columnar epithelium with thin, smooth muscle. Now, the next stop is the prostate gland because, not because, it is the prostate gland. It's the next stop, and it produces the other percentage of the seminal fluid. We said that the seminal vesicles produce 70%, it produces the other 25%. Has just the epithelium, the tubular alveolar glands, and the fibromuscular stroma. In an old prostate, you would see all of that plus prostate stones or corpora amelia, which develop in the lumen of the lumen. Yeah, it's in the lumen of the tubuloalveolar glands embedded in the fibromuscular stroma. And this question was brought in our exam, so make sure you remember this, or this concept was tested in our exam. So the main idea of the male reproductive system and histology is that all of them are pseudo-stratified columnar epithelium, except for two things, the epididymis and the vas deferens, which become a continuation of each other towards the end. They have pseudo-stratified columnar epithelium plus the stereocilia. And the seminiferous tubules have germinal epithelium, which is columnar epithelium, because they're lined by Sertoli cells. Okay, so it moves seminiferous tubules, epididymis, vas deferens, ejaculatory duct, seminal vesicles, urethra. All right, we're good. Now we're moving on to the zones of the prostate, which is very important, and it's always tested in renal and endorepro, and probably no, not GIT. Okay, just renal and endorepro. So the purple part here is the transitional zone, which surrounds the prostate urethra, and 5% of the glands are here, which are mucosal glands. Then this part is the central zone, and it surrounds the ejaculatory duct, and it has 25% of the glands, which are the submucosal glands. And then you have the peripheral zone, which is the brown part here, and it has 70% of the glands, and the main glands are here, okay? All of these glands are buried in the fibromuscular stroma, which is the collagen and the smooth muscle, and the glands of all the ducts merge together and bring all the secretions to the posterior wall of the urethra, okay? Okay. Now the cancers of the prostate gland. Most cancers originate in the peripheral zone, which is this one right, no, this one right here. And this is where 70 to 50% of cancers originate. And the posterior aspect of this zone can be examined by the digital rectal examination. The transitional zone, which is the purple part, is where 25% of prostate cancers originate here. And the most common one here is the benign prostate hyperplasia. And the nodules compress their urethra and make urination difficult. So whenever they're bringing a question about this, they'll say like a 60-year-old male with difficulty urinating and something like that. The central zone has very few cancers. So the most common, the one that you guys need to remember the most is peripheral and transitional. Transitional BPH, peripheral zone is where most cancers originate. Now, a question for you guys. A surgeon wants to reach the parenchyma of the testes. Through which layer must he get through to reach it? I'm gonna give you guys a second. The answer is A, because Buck's fascia, we don't even mention that. Colles fascia, Scarves fascia, we didn't mention any of these. Tunica albuginea is the collagenous connective tissue layer, because we have the scrotum, the tunica vaginalis, which is the serosa one, the one that has the pride on the visceral, and then we move over to the actual gist of it, the parenchyma, which is the functional part. Now, moving on to the female reproductive system. Now, the female reproductive system, the main idea is that all the epithelium is simple columnar epithelium. And this is seen in the fallopian tube, the uterus, and the proximal part of the cervix, because the cervix is divided into two, endocervix and ectocervix. So endocervix, you have the simple columnar. And then when you move over to the distal part of the whole system, you have ectocervix, which is stratified squamous epithelium, non-keratinized, and then the vagina, the stratified squamous epithelium, non-keratinized. Do you see like this pattern? Do you see how it's like it goes up and then down, and then they're all the same epithelium? That's very nice. I like that in repro. Now, in the transition part between the endo and the ectocervix, it's a place for cervical cancer, and it's the most common site for cervical cancer. And how you diagnose it is that you do a pap smear and a microscopy of the cervical epithelial cells. Now, let's start from up to down, okay? So let's begin in the ovary. The ovary is lined by germinal epithelium. Dr. Annie says it's not the correct name because it's not producing eggs. The eggs are below it. But yes, it's called germinal epithelium, and it's simple squamous or cuboidal epithelium. The germ cells are extra gonadal in origin, and then they migrate from the embryonic sac to the cortex of their embryonic ovary. And the clinical part of this is that the origin of 70% of ovarian cancers occur here. Now we have the tunica albuginea, like how we had in the male reproductive system, where we had scrotum and then tunica vaginalis and then tunica albuginea, which is the connective tissue part. This is also dense connective tissue. And below it, like directly, we have the primordial follicles, which are the dormant ones that stay dormant for 12 to 15 years to 50 years. Because we have actually 300,000 of them at birth. Some of them die, some of them are lost during menstruation, and you end up having a lower number. And then you have the cortex, which is where after puberty the stages of development will occur. So right under the tunica albuginea. And then you have the medulla, which is not seen here, which is loose connective tissue, and it has the blood, the lymphatics, the vessels, the nerves. Now, I put all the phases of the eggs in one slide to summarize it all for you guys. So this is why I said go through Dr. Annie's presentation before or after. So let's start with the first one, the primordial follicle. It's a primary oocyte, so it means it's not a haploid yet. It has no zona pellucida, and it's simple squamous follicular flat cells. The basal lamina and the stromal cells are surrounding it. And then we move to the early primordial follicle. Primary oocyte, and now the zona pellucida occurred. You can see it here, it's present. And the epithelium changed from simple squamous to simple cuboidal, and the basal lamina and the stromal cells are also surrounding it. And now we move on to the late primary follicle. The late primary follicle is a primary oocyte. It has a zona pellucida, and the epithelium changed from simple cuboidal to stratified cuboidal follicular cells, and the basal lamina and the stromal cells are surrounding it. But it has a different name this time. Instead of granulosa, and instead of it being called follicular cells, it's now called granulosa cells. And instead of it being called stromal cells, it's now called theca cells. Now we move on to the secondary follicle. Now it's getting serious. It's a secondary oocyte now, undergoed meiosis, so it's a haploid, but it's arrested in the second phase of meiosis 2 and metaphase. And it has zona pellucida, stratified cuboid follicular cells, so it didn't change. And then now the antrum shows up, which is like the slake, which has ECF in them. The theca cells become the theca interna and the theca externa. I'm going to zoom in. The theca interna and the theca externa, you can see them here. Now, the theca interna make the androgens and give it to the granular cells to make estrogen from the androgens. And then lastly, we have the Graafian follicle, which is like the biggest one, and it's the maximum size it's going to get. Secondary oocyte arrested in meiosis 2 in metaphase, one pseudo, stratified cuboidal, nothing changed here. Around the oocyte is a granulosa cell, which will become the corona radiata, which is, I'm pretty sure it's in this picture. No, it's not. I think it's in the next slide. After ovulation. And then the antrum is filled with way more ECF than before. And it surrounds the secondary oocyte and it pushes it to the side. So during ovulation, it can just push it out. Just a second. Okay, so that's it for the ovary. Now the fallopian tube. The fallopian tube is surrounded by simple columnar epithelium with cilia. And it has a muscularis layer with the inner circular and an outer thin longitudinal layer. And the place of fertilization in the fallopian tube is the ampulla. Again, I only included the important parts, which I think you're going to be tested on based on previous batch questions and the review. Now, after the ovary, it moves from the fallopian tube to the uterus. The uterus has simple columnar epithelium with uterine glands. Just a sec. As I was saying, the uterus is lined by simple columnar epithelium with uterine glands, and it has two layers, the stratum basale and the stratum functionale. The stratum functionale is the one that grows and dies and grows and dies during menstruation. So this is the stratum functionale, and this is the stratum basale. The endometrium is simple columnar epithelium with endocrine, with uterine glands. And then you have the myometrium, which is the smooth muscle, and again, it's longitudinal, inner longitudinal, middle circular, outer longitudinal. And then you have the perimetrium, which is the serosa, and it's lined by mesothelium. Now, lastly, wait, not lastly, yeah, cervix, the cervix of the uterus. You have two parts of it, as we mentioned before, the endocervix and the ectocervix. Ecto or exo? I'll check on that later. Endocervix, simple columnar epithelium, plus the uterine glands, and then you have the abrupt transition of epithelium to stratified squamous epithelium. So you can see here, simple columnar with uterine glands, and then boom, stratified squamous epithelium, non-keratinized. And the clinical part of this is that it's the main site for cervical cancer, and diagnosis can be done through a pap smear or microscopy. Now we move on to the vagina, and it's lined by stratified squamous epithelium, non-keratinized. It's a continuation of the exocervix, and it has no glands, smooth muscle, inner circular, and outer longitudinal, and the function is it's the birth canal. So you can see this is a mucosal layer, the stratified squamous epithelium, which is a lot of it, and then you have the muscular layer, which is the inner circular and the outer longitudinal. Now you have the phases of the uterus. So the uterus undergoes three phases. The proliferative phase, where the glands appear straight and less. The secretory phase, which the glands appear more convoluted and they actually become way more glands. Because if you can see here, is the proliferative phase where there's FSH and estrogen right after menstruation. Here, the dotted line is the border between the stratum basale and the functionale. You could see that there's less glands here, but then after the LH surge and ovulation in the secretory phase, there's way more glands, and there's the maximal thickness of the endometrium. The spiral cells begin to appear here, and it extends into the superficial regions of the functional layer, which is the stratum functionale. And then no fertilization occurs, so menstruation happens, and the stratum functionale dies and falls off, and then bleeding occurs because the spiral cells extended into the functional layer, which is the stratum functionale, and when it's gone, bleeding occurs. Now, a question for you guys. What are the layers of the endocervix and ectocervix, respectively? B, simple columnar and stratified squamous. Because this is also a question in our exam, by the way. The endocervix, simple columnar, and then we go here, stratified squamous, and then the vagina also has stratified squamous, non-keratinized epithelium. Now, this has been a long session. We finally made it to the end. Breast and placenta. So the breast has I'm assuming you guys already know this, so I'm just like crash coursing you guys. We have 15 lobes to 20 lobes in the breast, and each lobe has one compound tubulo-alveolar gland, 15 to 20 of them. one compound means like 15 to 20. Okay. So, and each of them has 10 to 100 acini or ductules in the unit of it. And it's simple cuboidal epithelium with myoepithelial cells to eject the milk out. So that's the lobe, and then the acini in it, and then the ductules, and then it moves over here, and it becomes the intralobular collecting duct, again lined with simple cuboidal epithelium with myoepithelial cells. And then it becomes the lactiferous duct. And in this duct, it changes from cuboidal to columnar with myoepithelial cells. And then we move again to the lactiferous sinuses. And these sinuses have two layers of cuboidal cells. And then we move again to the pores, where near their openings, they have stratified squamous, keratinized epithelium. And then finally, the nipple. So that's like the whole way there. And I labeled them for you guys here. Now, the breast, in a histological picture, it's different when from the lactating and the non-lactating breast. In the lactating and non-lactating breast, you can see that the stroma is way more than the TDLU, the lobules. It's way more pink, and the lobules don't have any milk in them. And you can also see adipose tissue here, and they're very small. While in a non-lactating breast, in a lactating breast, you have way more lobules than you have stroma, and you could see milk in the TDLU. And the acini are large because it's a lactating breast. Okay, now to the clinical part. Ductal carcinoma in situ. Ductal carcinoma, ductal as in this part. Oops. The ducts, the lactiferous ducts, these ones. The ductal carcinoma in situ. In situ means that the carcinoma is occurring, but it didn't cross the basement membrane yet, so it's not invasive yet. And this develops from the simple columnar epithelium of the ductal cells. But when it crosses that basement membrane, it becomes invasive. And the cancer again originates in the simple columnar epithelium, and 80% of breast cancers occur here. It crosses the basement membrane and becomes invasive. Moving on to the lobular, which is this one, no, not this one. Lobular, this was the ductal, this was the yeah, it is number 3. It develops in the lobule, which is simple cuboidal epithelium with of the TDLU. And metastatic breast cancer occurs here because the cancerous cells can go to nearby capillaries, which are very leaky, making it easier for the cancer to enter. So we have carcinoma in situ, ductal carcinoma in situ or in situ, invasive ductal carcinoma, and then finally invasive lobular carcinoma. Now, the blood supply of the breast. Dr. Annie really emphasized on this, so I think you guys should have this memorized like your name. Also, I actually think I made a mistake. Number 3 is the sinuses, not the lobules. The lobules are like right before the ducts, so it'd be here. And that's why they're so close to the lymphatic vessels. Now, blood supply. This is very important, as I said. So the blood supply of the breast comes from the subclavian artery, the axillary artery, and the thoracic aorta. The subclavian artery gives out the internal thoracic, and it gives perforating branches on this side of the breast. And then the axillary artery gives off the lateral thoracic artery and the lateral branches. So it supplies this part of the breast. And then the thoracic aorta has the intercostal arteries, which also supply the posterior portion of the breast. And you also have the drainage. The drainage is literally the opposite of the blood supply. So the lateral thoracic that came off the axillary goes back into the axillary. The internal thoracic, which came from the subclavian, no, there's no subclavian, goes into the axillary. And then the posterior intercostal goes to axillary. So all of them just go into axillary. Now, we move to the lymphatics. The breast has quadrants, okay? It has the lateral outer quadrant, the medial inner quadrant, and the inferior lower quadrant. So the lateral outer quadrant drains into the axillary lymph nodes. And this is very important. Why? Because 60% of breast carcinomas involve this upper lateral or outer quadrant, and they tend to spread through these axillary lymph nodes. And these nodes are located posterior to the lower border of the pectoralis major muscle, which I don't think you need to know, but it's okay. Medial inner quadrants drain into the parasternal lymph nodes, and these lymph nodes are located along the internal thoracic artery. Finally, the inferior lower quadrants drain into the abdominal lymph nodes, and yeah, that's the drainage. So axillary, parasternal, and abdominal. Now, The nerves. The nerves supply is similar to the blood supply. You have the 4 to 6 intercostal nerves, which is like the blood supply. You have the supraclavicular nerves. You can remember, subclavian gave internal thoracic. So supraclavicular sensory nerves to the skin and the breast. And then you have some sympathetic nerves, which are to the smooth muscle of the breast and the smooth muscle of the blood vessels. And then you have the myoepithelial cells contract in response to oxytocin. So oxytocin from the posterior pituitary are released, and then they contract. Now, here's a question for you guys. There is a tumor in the lactiferous duct. Identify what type of epithelium it is. I'll give you guys a second. It is simple columnar because we said it moves from the lobule to the duct, from cuboidal to columnar. Here, cuboidal, and then it becomes columnar. So this is very important, like change. So make sure you remember that. Now, finally, the placenta. The placenta is the communication between the mom's blood and the baby's blood. Originally, it is 6 layers. So you have the syncytial which is the pink, this one. You have the syncytiotrophoblast pink. You have the cytotrophoblast. It goes to syncytiotrophoblast. Cytotrophoblast, you can see it here, cytotrophoblast. And then they share the basement membrane for both the trophoblasts. It's not on the image, but they share one basement membrane. And then the mesenchyme, the core, which is the purple part, and then the basement membrane of the endothelium of the fetal umbilical capillaries, and then to the endothelium of the fetal umbilical capillary. It goes to the basement and then to the endothelium. So basement membrane, endothelium, and exchange can only happen to the capillaries. Make sure you remember that. So it happens originally 6 layers. This is the baby side, this is the mom side. And the placental villi with gas exchange, okay? Now it was originally 6 layers. Now it's going to be 3 layers. The syncytial trophoblast, the fused basement membrane of the 2 trophoblasts that we mentioned here, and the endothelium of the umbilical capillaries. So we skipped this basement membrane part, and the mesenchyme shrinks, by the way. So again, the cytotrophoblasts atrophied from the 4th month. The fused basement membranes of the both trophoblasts and the mesenchymal core shrinks. This is the 6 layers, and these are the 3 layers. So again, the cytotrophoblast and the cytotrophoblast atrophies from the 4th month. They fused the 2 basement membranes of the syncytiotrophoblasts and the endothelium of the umbilical capillary, and the mesenchymal core shrinks. I think I said the fused membrane of these 2, but no, I meant the fused membrane of the syncytiotrophoblast and the endothelium of the umbilical capillary. And the mesenchymal core shrinks. So you can see here, these are the 6 layers, these are the 3 layers. The cytotrophoblast is present only mature erythrocytes with no nucleus. The erythrocytes here have nucleuses, and the mesenchymal core is very large, you can see. The mesenchymal core is minimal here. So yeah. And this is the fetus's side, this is the mom's side. You have the decidual cells, which are specialized stromal cells of the endothelium under the embryo. It forms the maternal side of the placenta and is the connection between the fetal blood and the maternal blood. And then here, the microvilli sits towards the endothelium. Now, in the term placenta, you can see a few cytotrophoblasts left, but in yellow, you can see the placental macrophages. In orange, you can see the umbilical arterial or venule. In green, you can see the umbilical capillaries. In pink, you can see the red blood cells in the umbilical capillaries. And this is the mesenchyme. The collagen shrinks, the mesenchymal core shrinks to make the 3 layers. And that is it for the crash course. I hope this benefited you guys, and I'm so sorry if I seemed all over the place. Please don't hesitate to ask any questions. My number was in the beginning with my email and everything. So if you have any questions, please let me know, and please scan this QR code. Thank you, guys.